Hi, and welcome to our fourth week in the halfway mark of your instrumentation and physics course for point of care ultrasound. I hope that this has been a little bit helpful, and today's lecture, I think, will be a big step in building some confidence in how you're using your transducers and the selections that you're making, which will hopefully translate to much easier scanning without fighting with your equipment. So objectives for today is we're going to describe the construction of a transducer, explain how a transducer generates ultrasound pulses, explain how the transducer receives echoes, describe a sound beam and list the factors that affect it, discuss how many beams are focused, discuss how sound beams are focused and automatically scanned through anatomy, and then compare linear, convex, phased, and vector arrays, define and differentiate between detail resolution, and list the factors that determine detail resolution. So our transducers, as we've talked about in previous lectures, consist of basically the active components of our sound wave system. So our transducers, the face of a transducer will usually look something like a little matrix made up of all these things we call our piezoelectric elements. So across the matrix of this transducer, we would have many, many little tiny elements. And each of those elements would be what we call a piezoelectric element or crystal sometimes that people refer to it at. Now, when a piezoelectric element is an element that's typically man-made. Most of the time, these are being made as lead zirconate titanate, and they're being made by applying a lot of pressure to the lead zirconate titanate with electrical charge, and that gives it what we call piezoelectric qualities. Once it has a piezoelectric quality, when it is acted upon by a voltage, electrical voltage, it will cause that piezoelectric element to expand and contract. And as it expands and contracts, it produces a sound wave. So our transducer up here, if I look at the transducer face, it would have many little piezoelectric elements. Each of those piezoelectric elements is going to have its own voltage signal through a particular channel. So by applying a voltage through a channel to an element, I can create a sound wave. Now, once that sound wave is produced, with our pulsed wave sonography that we use in imaging, we would follow the production of that wave by a listening time. And during that listening time, that piezoelectric element would be waiting to absorb sound waves. And when the sound wave acted on that element, it would expand and contract just like before, and it would then emit a voltage signal up the channel. And it's from that voltage signal that we would get our echo information that would allow us to place a bright dot on the image and ultimately see anatomy. Now, one important note about the piezoelectric elements is that because they're man-made under lots of pressure and high heat to give them those piezoelectric qualities, is if we ever get that element up to the Curie point again, it will lose its piezoelectric qualities. So we have to be careful with our transducers. This is not something that you can put into an autoclave or something like that. Of course, in normal environments, they're going to do just fine, but it's something that to be aware of anyway. Now, each of those elements are secured to one another to hold their form with a polymer in between. And so that polymer will fill in the matrix and give a nice stable component to the transducer face. Each element, as I mentioned before, is driven by its own voltage pulse. So if this was one particular element, here's another one, so on and so forth, and we know they're arranged in a matrix. If I were to look at each element microscopically, we would see that each one of them has its own electrical channel. And through that electrical channel, it receives its voltage input, causing it to make its piezoelectric reaction to produce sound. And then when sound returns, we'd have that reversal where we have sound causing the piezoelectric interaction, producing a voltage. Now, each voltage cycle of sound, so when we say cycle, we're really looking at one complete positive and negative cycle of the electrical charge. When we have one complete cycle of voltage, it will produce what we call one pulse of sound. And our pulses of sound that we use in diagnostic imaging is usually 2 to 3 cycles in length. So one voltage produces one pulse of sound. And like I mentioned on the last slide, then that pulse of sound would be followed by listening time, allowing time for that sound to interact within the body, come back and deliver signal to the piezoelectric element. Now, what's really interesting about this is that elements have certain capabilities. So the size of the element, different things about the element can determine what frequencies they can produce. Now, fortunately, a lot of elements have what we call a bandwidth, meaning that there's not just a single frequency that that element can produce, but it can maybe operate between 1 megahertz and 5 megahertz, or something along those lines. And so we're able to actually manipulate the frequency in which these elements are producing by adjusting the frequency of the voltage that we send to the element. So by changing the frequency of our voltage cycle, we can change the frequency produced in our sound waves within reason, within what our element is capable of. So there's a couple different ways as the operator, and this is going to be very, very useful to you and prevent a lot of frustration. There's a couple different ways that most systems are set up that the operator can control the frequency. We know that high frequency sound waves provide us with the best resolution, but they also give us limited penetration or depth. So if we're scanning somebody that maybe has a really fatty or fibrous or cirrhotic liver, and we have a relatively high frequency, and we cannot get penetration, we will never be able to see the back part of that liver. It can become very frustrating. And so what we'd want to do is adjust that transducer so we had a lower frequency, which would be more penetrable and could get deeper into the patient. Granted, we would lose some resolution, but at least we'd be able to get some imaging of the depth that we're going for. So the ways the operator can control this is either through direct controlling, which GE uses a direct control of frequency, where if I have a transducer that says that it can operate between a 1 and a 5 megahertz, it would allow me to change my frequency directly from 1 to 2 to 3 to 4 to 5. So I could make that change to get the penetration I needed with the best resolution I could get. Now, other systems such as a Philips, and I'm sure others, have more of an indirect approach. So on the Philips system, I might have that same transducer that says that it operates between 1 and 5, and I'm scanning a liver and I can't get to the posterior aspect of the liver because my attenuation is eating up all my beam. So I would know I want to reduce my frequency. And it doesn't have a direct frequency button where I could just go from 5 to 4 to 3 to 2 to 1. What Philips has is something called res, which would be your high resolution, which indicates higher frequency. It would have gen, which would be your moderate resolution and your moderate frequency. And then it would have pen for penetration, which would be your low resolution but low frequency. And so this would be by adjusting from gen to res to pen or vice versa, this would be an indirect adjustment of your frequency. So it's going to be important that whatever system you are working on, you find out how to adjust your frequency, and we can certainly help you with that because there's going to be times when that's absolutely essential to accomplish what you're going to be trying to do. Now, the transducer assembly, so the piezoelectric element that we've been talking about is represented here in the blue. And I'm going to briefly discuss this because it's not something you're going to be utilizing a lot. But one of the things that's important to recognize about our transducer assembly is that behind the row of elements that you see here, we have something called a backing material. And I kind of relate this to if we have a bell and we ring that bell, and there's nothing to stop the bell from ringing, it will continue to taper off in its sound production, but it will continue to ring on for a longer period of time than we might intend. The same thing kind of happens with our piezoelectric elements. When that channel provides a voltage and the voltage causes that expansion and contraction of the piezoelectric element, that may not just expand, contract, and stop. It might ring on. And when it rings on, it's producing a pulse that is going to kind of taper on and on. When we have that, it decreases our resolution. So in order to prevent that, they add this backing material that I kind of think about like wrapping a pillow around the bell. You ring the bell, compress it with the pillow, it stops it so that you get a much more defined stopping point of your pulse, and that's going to provide us better resolution. Now for you guys, that's probably not something you want to worry too much about, but just a little background on why it's there. Now what you would want to be more interested in is this layer in front of our elements. This is called a matching layer. So when our sound is produced in the element itself, it's going to be moving through that piezoelectric element at the propagation speed of whatever our element is made out of. Now, that propagation speed is usually very high, and so if I were to take this transducer and touch the elements directly to the skin, there would be a huge change in propagation speed between the skin and the transducer element. And because a huge change in propagation speed means a huge change in impedance, all of my sound would be reflected back at me and I wouldn't get any penetration into the patient's body. So, in order to prevent that, manufacturers will insert matching layers and sometimes multiple matching layers that are intended to ease the propagation speed from what it is in the element to what it needs to be to transmit the patient's skin. So when you look at the face of your transducer, you're going to see a gray or red or something covering, almost like a rubbery material, covering these elements, protecting them, but also acting as a matching layer to allow the sound to ease itself into the body without being all reflected back. If there is damage to that matching layer, then you may have some issues and you might see dropout in part of your image. Now this one shows an acoustic lens, which isn't necessarily utilized as a large part of our probes that we're using currently. So I'm going to just leave that out of our discussion today. Now the last thing that we have is coupling gel, and we always think of coupling gel, it's kind of like our KY jelly. It'll work. It's our ultrasound gel. A lot of people think of it as it just allows lubrication so we can move the transducer on the skin. But what really it is doing is it's acting as another matching layer to allow us to get penetration into the patient. So if you have your transducer on your patient and you're seeing a lot of dropout in different areas, that's when you're going to want to add more gel. It probably means that your line of gel is too thin and you're getting reflection back because you're not coupling it or matching it to the propagation speed within the patient. Okay, so we already talked a little bit about operating frequency, and you'll see when you look at a transducer, usually your transducer will state in numbers on the transducer itself the frequency range of that particular transducer. And we know that a couple different things are necessary in order to get a transducer to operate at a certain frequency. First of all, depending on the element thickness is going to determine the frequencies available to that transducer. The thicker or the larger my elements, the more dramatic their expansion and contraction, the longer the wavelength would be, and therefore the lower the frequency. If I have a much thinner or smaller piezoelectric element, its expansion and contraction would be much more brief and defined. I would get a much higher frequency. So within reason, there's going to be a variety of frequencies that a particular element thickness can produce. The larger elements are going to be the lower end frequencies. The smaller elements are going to be the higher end frequencies. The element that particular element or piezoelectric element's propagation speed also plays a role in which frequency it can produce. So if I have a transducer made of all of these very small elements with a high propagation speed, then that particular transducer might be capable of something like a 9 to 15 megahertz frequency. Because it's so small, it simply could not, no matter what I changed, it would not be able to function as an element this particular side, which might be a 1 to 5 megahertz frequency. Now that range of frequencies that's possible, 9 to 15 or 1 to 5, would be considered the bandwidth of that particular transducer. So the bandwidth of your transducer is written on the side of the transducer, and it tells you what frequencies you can operate it at. Now let's say that I'm using a 9 to 15 megahertz transducer that has all these very small little elements. They would be capable of any frequency within that range. And I'm trying to scan, say, the popliteal vein, and it's diving a little bit deeper as it proceeds towards the calf. And all of a sudden, my really high end of my frequency is not getting me the penetration that I need. I could adjust my frequency from the 15 to the 9, either directly or indirectly, as I mentioned. And as I changed my machine settings to obtain a lower frequency, what would happen is that channel that was stimulating the element in the probe would change the voltage from being a high frequency voltage to a slightly lower frequency voltage. And when that voltage changes, the voltage or the frequency of my sound wave mimics the change in the frequency of my voltage. Now, fortunately, your machine takes care of all of that. So what we have to be able to concentrate on is how do we change our frequency? What settings do we change to change our frequency of our transducer when we need to do that? And then the computer or the instrumentation system takes care of it from there, changes the voltage, and that voltage will allow it to operate at a different frequency as long as that frequency is within its bandwidth. Now, bandwidth, as I mentioned, if I have a 12 or an 8 to 12 frequency transducer, it means that's my bandwidth. I could operate anywhere between 8 and 12. So I would have a bandwidth of 12 minus 8, which would be 4. Now, I could operate anywhere in there. This I would have higher frequency. This I could bring my frequency down and get more penetration. That would be my bandwidth. Now, another important concept when we're talking about bandwidth is harmonic imaging. And most of your systems are going to have a button on it called harmonic imaging, or sometimes you'll see it listed as when you select your frequency. Say you've selected a frequency of 8. You might see 8 megahertz with a capital H in front of or behind it. And that would mean your harmonics are on. Now, what harmonics are, it's a little bit complicated. I'll try and keep it pretty simple. But when we first talked about sound propagation in the body, we said that as sound propagates through the body, it compresses and refracts. And when it compresses tissue, it's going to cause tissue molecules to increase in their density in that area. And when it refracts, it is going to have it's going to allow the molecule density in that tissue to expand out. Well, we know that sound actually travels faster or at higher frequencies when it's going through a stiffer material. So as we get to this top of this waveform and we have a stiffer material because of the particle density increase, we actually see the frequency increase naturally. So if I'm using an 8 megahertz transducer operating at an 8 megahertz operating frequency, and I'm emitting sound into the body, that sound's going to have areas of compression and refraction, and those areas of compression are going to result in increased frequency in those particular areas. Those increased frequencies in those areas are called harmonics. Now, harmonics are higher frequencies than I'm operating at, and they're multiples of our operating frequency. So if 8 is my operating frequency, I turn on harmonics, I will be listening for 8, 16, 24, so on and so forth frequencies. Okay, so when I turn off harmonics, it doesn't mean that I can stop these additional frequencies from occurring in the patient. We know they occur as sound transmits through a patient. What we simply do is we tell our transducer, stop listening for anything, any multiples of our 8. I want harmonics off. I'm just going to listen for my 8. So it might be receiving harmonic sound waves back, but it's not registering them for the image. Now, you might wonder, well, why does this even matter? So the reason this matters probably for you is that if we turn harmonics imaging on, and I'm imaging at an 8, and I am listening for frequencies that are multiples of that 8, like 16, 24, 32, so on and so forth, those are high frequencies. And one thing we know about higher frequencies is that as we increase frequency, we also increase our resolution. So maybe you're placing some kind of a PIC line or something else that you want really good resolution of the tip of that needle or catheter. Well, it might be useful to turn your harmonics on so that you get greater resolution of that area. Now, other times you might be scanning something like a cirrhotic liver or something that's very dense and difficult to penetrate. You have your harmonics on and you can't figure out why you can't get imaging in the back, in the posterior aspect of that organ. That might be a good option where you want to turn harmonics off and go for more penetration and stop listening for those higher frequencies. So again, that's a lot of information you don't necessarily may or may not use, but that's the reasoning when you're setting some of your settings. That's why you would want to consider making those changes if you're struggling to visualize what you want. Okay, now we're going to talk about some of the particular transducers and when you're going to use these transducers. Now, I debated on whether or not to even include the continuous wave transducer in this lecture, but I decided to go ahead and do it because we do see this used sometimes, especially during echo. So here is an example of a continuous wave transducer produced or utilized in echo. And what a continuous wave transducer is, it breaks all the laws of what we've talked about so far, where we talk about pulsed wave transducer, where we pulse, we listen, we receive echoes back, and then we pulse again. And we time the time it took to receive our echoes back, tell us how deep they went and where they came from. Now with continuous wave will typically have just two separate elements, one to transmit sound and one to receive sound, and they're constantly on. So they have no listening or off period. So they're constantly bringing back information. Now the thing is here, however, because we don't know how long the sound has been gone for or when it came back or the direction it came back for, we can't produce an image out of these. So for continuous wave, we have no image production. There's no pulsing. We send and receive sound at all times. Because of this, we are able to determine Doppler shifts, however. If I have a constant frequency coming out, it's getting bombarded or ran into by my blood cells, that's going to cause a Doppler shift, what's going to be recognized on my receiving element. And because of that, we are going to detect Doppler shifts, and we're going to be able to get a spectral Doppler out of these continuous wave transducers. Now, one of the reasons they get used in echo is because usually these are a little bit more sensitive to very, very high velocities. And so they can be a useful tool in that manner if you decide to use them. Okay, now the transducers that we typically use are pulse wave transducers, where we produce a sound wave, as you see here, and then we stop producing that wave and we listen until it's time to produce another wave. Okay. Every time we produce one of these pulses, that pulse is going to go into our tissue, and it's hopefully going to reflect off of multiple different anatomic parts, and it's going to return back, providing us a sound information, which will be converted to a voltage, which will be eventually converted to an echo that appears on our image. So for every single pulse that we emit, we should produce about one scan line. Now, when we're using these pulsed wave transducers, we can produce our B mode or our black and white images. If we happen to overlay a color mode image over that, we can produce that with a separate scan, with an additional scan line in that same area, or a superimposed scan line. And then the same is true for our spectral. We would have to add one more layer. So we'd have a B mode pulse producing my B mode scan line, another pulse producing my color scan line superimposed over that, and then a third pulse producing my spectral information, which would be represented just below. So that's our pulse wave transducers. We have to have the listening time to tell us how long our sound's been gone for in order for us to know where it went and where the echo is coming back from. Now, to make our pulsed transducers just a little bit more complicated, we have something called phasing or phased array that allows us to have a little bit extra control over pulsed transducers. So we know that a transducer is made up of a matrix of many, many, many different elements, usually around 256 or maybe a little bit more. Each element has its own channel or its own feeding line of voltage. Now, one of the things they found when they studied this was that if I applied voltage with a slight delay, so let's say here's my elements, each element has a channel, and if I provided each element a voltage with a slight delay between the first and second element, and the second and third, and so on and so forth, the first sound wave produced would be inclined to go towards the center of the transducer. And then as the second came through, because it didn't have anything over here blocking it, it would go towards the center of the transducer. So by doing what we call phasing or adding slight delays to the voltages that are sent to our elements, we can actually steer our sound waves in one particular direction. Or if I had signaled my right side first and then gradually to my left, it could steer it in a different direction. Now, you're doing this all the time if you're steering your color box on a linear scan. Now, another way that this can be used is to adjust our focus. We know that our focus allows us to optimize lateral resolution. So lateral resolution is the representation of two different parts that are separate items side by side. With good lateral resolution, my sound wave squeezes in between those two parts and provides information between those two parts so that when I see it on the image, it accurately represents two different parts on my image. Now, if I have poor lateral resolution, a wide beam will interact with those two together. It won't provide information from between the parts, and when it gets written on my image, it will look as one large part. Okay. So that's a really important component of lateral resolution. Well, we know that focusing our beam causes it to narrow at my focus. And so if this is my beam and I want it to be narrow here to squeeze through, let's say ovarian cysts here and here, I would want to set my focus at this level so that that would be the narrowest area of my beam and provide me the best lateral resolution in this area. Now, what if I'm still scanning and I see another pair of, say, fibroids higher in the uterus and they're up here? Well, no longer would I want my focus down here. I'd want it up here. So I could simply turn my button on my equipment to adjust my focus and bring it up higher. How does that happen, though? The way that happens is with our phasing. So rather than phasing from one side to the other like we did to steer our beam, we would phase in an arched manner where the arch of the delay or the phasing would cause it to come together at a certain point, to be narrowest or focused at a certain point. If I wanted to bring that focus up higher, then I would phase with greater delays. If I wanted the focus to be lower, I would phase with very much smaller delays, and that would cause my focus to move down. So when you're adjusting your focus, just briefly understand that that's what your system is doing. You're changing your focus, but your system is changing its phasing to allow that to happen. Now lastly, and I do think this is relatively helpful, a lot of your systems are going to have something called compound imaging. Now, compound imaging uses phasing like we talked about here, but rather than just producing one steered image one way, it would produce that particular steered image, and then it would phase in the opposite direction, produce another steered image, and then it might apply no phasing and produce a straight image, and it would overlay all those images together. It would produce a compound image of multiple different images obtained with different steering. Now, why this is important for you is one of the things that we can look for to give us clues about contents of an anatomic finding. For instance, if we have a cyst is usually anechoic internally, and then it has what we call posterior enhancement or a brightness behind it. And that's because there's less attenuation within that cyst. Now that's great. If I just have natural, normal, I'm focusing, but otherwise I'm just directing my beam straight down, I'm going to see this enhancement really well. If I do something like compound imaging, and I'm gathering information in this direction, this direction, this direction, and others, it's going to actually bypass in this direction and this direction. It's going to bypass that cystic structure and overcome some of that posterior enhancement. So it can fill in information. It can fix that artifact for us, but sometimes that artifact is helpful. And so it's important to understand that compound imaging is going to give you a smoother image. It's going to provide more information because it's layering detail of multiple different scans on top of each other. However, it can cover up artifacts that might give you hints to the cause or the components of a pathology. Now, lastly, wide scan. With certain transducers, they can steer an image one direction and the other as part of their compound imaging, and maybe take an image that should be linear straight down, and they can make it look wider than it should have been. And it can accomplish this through phasing. That brings us to our different transducer types. So here, this is an image of a bunch of different transducers. I think this group was made by GE. And in this group of transducers, we see a number of different linear transducers. So these are all linear transducers. They just have what we call a slightly different footprint, meaning this one's longer, its footprint is larger, just like a larger shoe size would have a larger footprint. This one's smaller, and then we have in between. They can also be linear with the same sort of shape, but have a different frequency, so they might operate better on certain specific exams. Our second type is our curvilinear. Curvilinear we see here, and again they have slightly different footprint between these two and probably a different frequency range. And then we have our 3 and 4D transducers, which you see here is very similar to our curvilinear, but it also has a greater depth to it. Then we have what we call a sector, which you see down here, where it has almost a pinpoint origin of sound waves. And a vector, which is very similar, but it's going to be slightly broader, a sector, but a little bit more width to it. And then finally, we have intracavitary, which would be like our endovaginal or endorectal probes, and then our interlumen, which would usually only be used in specialist type areas, such as transesophageal echoes and things like that, where the transducer is actually housed on the end of either a catheter or an endoscope or something like that. So when we look at some of these probes, our linear probe has what we call a linear footprint. It is a line. It's a line of elements arranged in a matrix. When we scan that linear probe, if we're not applying any special compound imaging or anything like that, our image will be a rectangle, just as like you see with this thyroid here. Okay. Now, with this, if I obtain this linear probe image, and then I had wanted to add color, and I needed to steer my color box, I could use phasing on that linear probe to produce a color box to overlay my scan. So our linear probes are usually going to be phased to produce compound imaging, to produce color box, to steer our color box, and things like that. It also has the wide scan option that I just mentioned, where it would be utilizing something like compound imaging, where it would steer one direction, steer the other direction, steer straight down, and overlay all of those, but it would give it with somewhat of a parabolic shape to get more tissue information in one view. Most of our linear probes are moderate to high frequency, and so they're going to run from like 5 megahertz to 12 megahertz. This means that they're going to have very high resolution, especially towards the 12 megahertz end, but they're going to have relatively low penetration. And so the depth that you're able to obtain from these transducers is going to be very limited. So some of the things that we use our linear transducers for are small parts like the breast, the thyroid, carotid exams, a lot of our vascular exams. However, because of their very limited depth, lots of times when you get to the deeper vascular structures, such as maybe the perineal arteries and veins or the iliac arteries and veins, you'd have to switch to a lower frequency transducer to accomplish what you're looking for. So if you're having trouble getting the penetration that you need with a linear, it may be that it's just too high frequency and you'll need to try something else. These are also great at looking at superficial structures or superficial vascular areas, like I mentioned, the carotid. They work well for those superficial musculoskeletal areas as well. Now, our curvilinear probes, they're very much like our linear, except they're arranged. It's basically got a linear group of elements, but they're arranged around a curved surface, convex surface. These are typically lower frequency than our regular linear probes. These are the probes that we're going to use for some of that deep vascular scanning. These are the ones that we're going to use for mostly all of our gynecologic or transabdominal gynecologic and our abdominal scanning. We get that lower frequency allows us for better penetration. If you're at the 5 megahertz, that's relatively decent frequency. You should still have pretty good resolution. If you're having to adjust down to the 1 megahertz end of its bandwidth to get the penetration you need, you're going to see a significant decline in your resolution. But sometimes that's a necessary evil to get the penetration that you need. The curvilinears that we use today usually allow use phasing, and that phasing is going to be instrumental in allowing us to adjust our focus. So if you see over here, it's not showing well. Usually you want your focus just at, say if I'm looking at my portal vein here, I would want my focus just at or behind the area of interest. And so by utilizing the phasing or adjusting my focus, my system would adjust the phasing to move my focus up or down. It can, some machines will even allow you to have multiple focuses at a time. That doesn't mean that it's focusing the image in 3 different places. It really means that it's producing 3 different images and basically layering them on top of one another. So with your curvilinear, it allows for effective imaging of your abdomen, pelvis, deep vessels, kind of like the perineal that I mentioned, and deep musculoskeletal, maybe like a hip joint or acetabulum, something like that. Then we have our 3 or 4D transducers. Now these really are like our curvilinears, except rather than just having kind of a shallow depth here of our matrix, they would thicken up that depth and make the matrix much, much broader. And this would use phasing basically to stimulate acquisition of layers and layers and layers and layers of information that would then be oriented in a volume. And then that volume would allow processing to occur and would allow the operators to scan through all the volume, or even to come out to the surface of the volume and look at a surface rendering like we see in this baby here. These work nicely. I think we talked about before about, you know, when you're trying to see the endometrial volume of a uterus or identify if an IUD is within the uterus, things like that. It works really well. Also great for bonding for parents, things like that. But once you're used to scanning in 2D, it's not going to provide you that much more information than you would otherwise have from your regular scans. The next type of transducer is a sector transducer. A sector transducer really has a pinpoint origin, and then it emits sound waves out in a pie shape. Now, these are usually moderate frequency, around the 5 megahertz transducer frequency, kind of like we had with our curvilinear. They have good penetration because of that, you know, moderate frequency. What's nice about these is they have a very small footprint. They can also use phasing to help them focus and operate with compound imaging. These work very well for a number of different things. Probably the thing you see them used most in is our echocardiograms. That very small footprint can squeeze right next to the sternal area in between the rib spaces, accessing the heart through the cartilage, so you're not getting rib shadows in your images. It's also used in neonatal brains to scan through their frontal soft spot and have that small footprint to get in there. And then it could even be used in your general abdominal imaging, such as you see on the bottom of this image here, where they're able to access in between the ribs more easily because of the small footprint. Now, a sector is very similar to a vector transducer. You'll just see that rather than that pinpoint origin, the vector has a little bit more of a linear origin, but still very small footprint. This one would produce an image that has basically a linear type origin, but it spreads the scan out in that pie-shaped format. These are, again, moderate frequency. This one you see here is a 4. They can be, you know, probably 3 to 5 or something like that. You don't necessarily see as many of these out and about today. They can use phasing for their focusing and all those other characteristics. But one good purpose of these that they were often used for is scanning in between the ribs of patients that are difficult to penetrate. That small footprint again makes intracostal scanning easier, and their lower penetration allows for good imaging of abdominal contents and things like that. That brings us to our intracavitary transducers. So these transducers, as I'm sure you're familiar with, are very small curvilinear elements at the very tip of a longer probe. And so these are relatively higher frequency, not as high as our general linear, but usually in the 5 megahertz range. They have good penetration, very good resolution, or pardon me, limited penetration with very good resolution. This is one of the main things we teach in our sonography students, is that because these have such fantastic resolution and limited penetration, we never ever do a gynecologic exam without doing a transabdominal first before a transvaginal. One of the purposes of that is once you insert this transvaginal transducer, if there were to be something large off of an ovary or maybe off of the fundus of the uterus, this transducer would not necessarily have the penetrative ability to demonstrate that problem. And so by adding a transabdominal prior to doing a transvaginal, we're taking more of a global look to hopefully not miss anything big that we would miss by this up close view that we do with the transvaginal. These can also be used for endorectal evaluations, especially of the prostate. Sometimes you'll see a slight difference with the endorectal rather than having the elements arranged on the tip of the transducer, they may be arranged on the side of the transducer to limit motion once in the rectal canal. Now, obviously covering of these, usually we recommend adding gel to the tip as a coupling layer, covering it with a non-latex probe cover or condom, and then covering it with KY jelly on the outside. That will allow good transmission of sound through those multiple different layers while protecting it from a lot of pathogens. When it's time to clean these, you slide the whole thing off, make sure all of the gel is removed. And the most popular approach to cleaning these currently is called the Trophon. It uses approaches without heat to kill any pathogens, which is going to be essential because we remember, you know, the sterilization techniques we would commonly be tempted to use would actually take the piezoelectric qualities from our transducers, and so those high heat temperatures are not an option for cleaning. So things like the Trophon or formerly Sidex, those kinds of things work really well to clean these intracavitary devices. Now finally, unless you're in a specialty or a lot of interest in this area, the intraluminal transducer is typically not that common to use. These are our highest frequency transducers. They're usually attached to either the end of an intravascular catheter or the end of an endoscope. So here you see it on an endoscope here. You know, when they're on an endoscope, they can be used for something like a transesophageal echo, where they would advance the endoscope down into the esophagus and provide them with that very up close view of the heart without having to fight through the sternum and ribs and everything else. So that's one approach. And here's an example of an intracatheter transducer where it's actually being advanced up a vessel. And with these, you'd obviously have the highest frequency, so the highest resolution, but of course a decreased amount of penetration. And then obviously these are going to be a little bit more invasive to the patient than just our general external scanning. Now, as you're scanning, transducer orientation is very important. All of your systems will have some type of marking that indicates how to hold the transducer. Of course, every manufacturer uses a different type of marking, but what's pretty constant is usually there's going to be some kind of stripe or divot on the part that you're going to aim towards your patient's head when you're in longitudinal. So if I had my hand positioned like this, my transducer would be longitudinal or in long, and if I placed that on the patient's body, it would show me a long view of a slice within their body. To get to transverse or axial, you're simply going to rotate your hand from this longitudinal view 90 degrees, and you should be at transverse or axial. Now here's an example where it's actually a phantom vessel, but here's a phantom vessel in long. So the transducer would be aligned like this, and it would obtain that slice of the phantom in long. By simply rotating the hand from that long orientation to the transverse orientation, the vessel would now look like this in transverse, a cross section. Now, it is important that when we're scanning, sometimes you'll hear long referred to as sagittal. When we talk about sagittal, we're really talking about the probe. Our probe is staying in line with the sagittal axis, with the patient's mid-sagittal line, basically. Long is now considered the more accurate term to use. If I have my patient's kidneys, say, that's a large kidney, I apologize, but let's say I'm scanning my patient's kidney and I want to see exactly how long that kidney is. I would have to orient my transducer in line with the long axis of the kidney. I would no longer be sagittal to my patient, I would be long to the anatomy. So we refer to any time we're extending an anatomic part out into its longest length, those are our long images. And to get from long to transverse, we need to rotate 90 degrees. Now, in this case, this long image comes at an oblique orientation to my patient. Another imaging window that we can use is our coronal view. So sometimes, especially with maybe the kidney or your adrenal glands or something like this, you would want to access through a coronal view of the patient. That would be scanning through their side with your transducer aiming into the patient. Okay. Now realize this is going to give you a slightly different cut or orientation of your anatomy. So it will often look similar to a long image, but it will be slightly different as you're getting it from the side of the patient, not the anterior aspect. Some of our other transducer approaches or orientations we can use would be parasternal. This is one right here just to the patient's left of their sternum. This is where a number of the different echocardiogram views are obtained from. We can do subcostal, which you find the patient's rib, the inferior aspect of their ribs, and you'd be scanning from under their ribs. Or you can go right to their xiphoid process right here and scan up into their chest or down into their abdomen from that area. So there's a number of different orientations and placements of your probe that are going to get you different windows. And we always say windows when we're talking about just different things that you can see through. So sometimes if I'm right here, transverse substernal area, I might be getting a lot of interference from transverse colon air. So I might have to try a different window to say, look at my aorta. Maybe I'd have to come coronally and scan through my patient's side, obtaining an image of my aorta, a slice of my aorta that looks something more like this. So lots of different options that you can work on your windows. Don't be afraid to move and try. If you're always thinking about it as a slice, don't be afraid to try different areas. Now, one of the things to mention is that if I have my transducer in long to the patient and I'm producing an image that looks something like this, to orient myself to the image, this would be the anterior aspect of the patient. This would be the posterior aspect of the patient. So again, this is long to my patient, and let's say my patient is supine. What would be to the left of my screen would be towards the patient's head. What's to the right of my screen would be towards their feet or caudal. So my patient would be laying this direction. This is anterior. This is posterior in my long orientation. Now in my transverse orientation, I would turn my probe from this direction, 90 degrees. And now I would have the anterior part of my screen would again be anterior part of my patient. The bottom part of my screen would be the posterior part of my patient. What was to my left would be my patient's right, and what's to my right would be my patient's left. Okay, now there's a number of different transducer movements you can use that will get your anatomy in the orientation you're trying to see it and allow you to scan through the tissue. It's a little bit different, I know, with point of care ultrasound, but one of the things we really push our sonography students to do is always scan through the entire volume of tissue before we ever take an image. So it's really easy to set the transducer down and see what you see and call it good, but we want to make sure that they're scanning all the way out of the organ from one side to the other, making sure there's nothing unusual hanging off an edge or anything like that. So, so these transducer movements are going to become very important in accomplishing that. So one of our transducer movements that we use is called angling. And so if my here is kind of represented by this tilting. If I'm holding my transducer, in this case it's transverse, and I am angling my probe one direction or the other, that would be angling, and it would allow me to scan through tissue. So if I'm looking at, say, the liver in transverse, and I have my probe here, I would use this tilting or angling to scan all the way out of my liver this direction, and then I would go the other direction, tilting or scanning all the way out that direction to obtain all of that information. Now, if I was in transverse, say over my right lobe of my liver, which is a little bit longer, and let's say my ribs kind of stop right about here, and I'm having trouble, I'm tilting and I'm angling and I'm trying to see up here, and I do okay, and then I come down here and I'm not seeing it very well. Well, now that I don't have to fight ribs or bony structures, I can actually slide my transducer down and access that tissue directly. So you can angle or tilt, or you can slide. Usually you're angling and tilting to get around gas, to get around bone, to get around things like that. You're usually sliding to get through tissue that's not covered up by something else. A good example would be through your femoral vein. You're usually going to be sliding down the vein, not so much sitting at one point on the vein, angling up or down. Okay. Another thing is rotating. So rotating, like I mentioned, for example, the kidney kind of lays at an angle. If I take my transducer and I put my longitude and I put it in sagittal orientation on that kidney, I'm going to get a slice of the kidney that looks something like this. I'm going to be missing the superior end. I'm going to be missing the inferior end. In order to be able to lengthen out that kidney and see it as it really lies in long, I'm going to have to rotate my probe. Now, sometimes you'll feel like you're rotating your probe out of normal orientation. Usually, like I mentioned in our last slide, we want the top of the probe towards the head in long, and we want the top of the probe or the notch in the probe towards us in transverse. Now, sometimes you're going to have to go opposite of that to lengthen out the organ, but once you reach, say, this point with the top of your probe, you've gone too far and you're probably going to end up confusing yourself. So rotating your probe is going to be essential in lengthening out anatomy. And then finally, rocking your probe, or this can be referred to as heel toe. So let's say if I am looking at an aorta and I am getting my aorta is looking something like this on my screen, and then I'm losing some tissue here. Maybe I need to rock my probe back and forth to try and make better contact to fill in this area. So I would be rocking it or heel toeing it front to back, something like that. Okay. Now there's additional maneuvers that you can do when you get used to, and once you've been scanning long enough, most of the time your muscles develop this muscle memory, and you're going to be able to move to the appropriate position without thinking much about it. I would say as a sonographer, that took me probably 1,000 hours to reach that point. It might be much faster, or if you're not scanning as much, it might take a lot longer. So it's just one of those things that you develop over time and with practice. So don't be alarmed if you're thinking, I know what I want on my anatomy, I know where it's at, but for some reason my image on my screen is not matching that. Don't be frustrated. It's the nature of ultrasound. So in summary, transducers are complex components necessary to an ultrasound imaging system. In order to visualize anatomy, they require the piezoelectric principle to convert voltage to sound waves and vice versa. Phasing of voltages applied to elements allow our beam control, including steering, compound imaging, and electronic focusing. Transducer orientation and movements are essential in obtaining accurate images and evaluating tissues. Thank you so much for joining me for another week. I hope that some of this information is useful in your practice, and we're looking forward to getting out and spending some hands-on time with you so you get to feeling very comfortable with your scanning and your equipment. Have a great week.